Here we go, guys. Welcome. Hope everyone is doing well. This is part of the Biomedical Cross-disciplinary series, the sort of final seminar of this unusual year. Appreciate everyone being here. Hope everyone is doing well. So what does the Cross-disciplinary seminar series do? Well, it's partly funded by the Integrative Medicine Department. Jeanette Rodriguez is the host of these seminar series, and Lee Frame, the director, and myself in Department of Pharmacology and Physiology, put this series together. So this is an annual series, and it'll be renewed hopefully next year. But the idea is to explore a cross-disciplinary topic each year to promote networking and collaboration in translational health among researchers, healthcare providers, and policymakers from across GW and beyond. So without further ado, it gives me great pleasure to introduce our speaker today, Dr. Sahib Khalsa, who's coming from Tulsa, Oklahoma. So Sahib received his BS in psychology from SUNY Stony Brook in 2002. He graduated from the University of Iowa, where he went through their medical scientist training program, where he received his MD and PhD in neuroscience in 2009. So Sahib has unique background in training, both in psychiatry and basic science, neuroscience. So he then went on to complete his residency in psychiatry at UCLA in 2013, where he was the chief resident at UCLA in their anxiety disorders clinic. It was in 2015 where Dr. Khalsa joined the Laureate Institute for Brain Research in Tulsa, where he currently is the Director of Clinical Operations and Associate Professor at the University of Tulsa. So Sahib is going to be talking to us today about what his laboratory studies and his interests, which are the intersection between the heart and brain connection, otherwise known as interoception. And so his lab is really at the forefront of this area. He's one of the pioneers leading this field. And his lab really wants to better understand the connection between brain-body mechanisms and how they influence both physical and mental health. So at his sort of early to mid-career stage, he has really done an impressive amount of work in this area. He's published over 80 papers and abstracts. If you want to check out one of his more recent in Trends in Neuroscience, recently published, is a really nice review article, as well as other articles on this topic of interoception, in particular neural circuits of interoception. So Sahib is also, in addition to impressive body of work with publications, he's been funded by the NIH, currently funded by the National Institutes of Mental Health, amongst other foundations as well. He has research funding from. And he's also received an impressive Young Investigator Award from the NARCED Foundation. So without further ado, Sahib, thanks again for doing this Zoom talk. And sorry, again, you can't be here in person with us and the cicadas. But yeah, we really look forward to your talk today. And if people have questions, you can put them in the chat box, or yeah, turn on your camera and ask away at the end. So we look forward to the talk and some discussion afterwards. So thank you.
Thanks, Paul. So this goes until when, roughly?
I think 1 o'clock.
1 o'clock. Okay. All right. So I'm going to try to summarize about a half decade or so of research in a very short amount of time. So I'll go quickly, but hopefully cover everything. So the title for my talk is Interoception and Mental Health. Thank you, Paul. It's been wonderful getting to know you over the last year and a half or so. And thank you for this invitation. It's good to be with you. So this word cloud here actually represents the output from a meeting called the Interoception Summit that I helped to organize in 2016. And so a lot of the words that you see up here, you'll actually see reflected in many of the themes of the research. And my hope is that by the end of this talk, you too will be sort of an expert on interoception. So I don't have any disclosures for this talk. I am located, as Paul said, at the Laureate Institute for Brain Research, which is in Tulsa, Oklahoma. This is an example of our campus. If you're interested in visiting post-pandemic, let me know. So I wanted to start by just illustrating a few case examples of patients that I've treated, just to kind of bring some of these concepts home clinically. So the first example is a patient who had severe avoidance. He was a 66-year-old man with idiopathic ventricular tachycardia, no prior psychiatric diagnoses, who underwent placement of an implantable cardioverter defibrillator for treatment and really rescue of ventricular arrhythmia. Now, this particular individual, after the first shock that he received, he wouldn't leave a 5-mile radius from his home for an entire year. He lived near the hospital, and he was worried that if he was away when something happened, he would get shocked and that would be the end of him. He wouldn't shower alone for 3 months, made his wife shower with him, and he wouldn't be in a room by himself for more than a year. So again, a severe avoidance fear. Another example that sort of epitomizes safety seeking, a 35-year-old man who began spending all his time inside of his local hospital after receiving recurrent ICD discharges. His rationale was that it was the safest place to be in the event of another shock. He actually would live in the public areas of the hospital, like the surgical waiting areas, where oftentimes you see people sleeping. And he would experience significant anxiety on leaving. He even purchased a stethoscope to better listen to his heartbeats, and he claimed that he could accurately predict his arrhythmia onset, followed by the shock with about a 3-second latency, even though he couldn't do anything to avert the unpleasant experience. Finally, switching gears to a different disorder, anorexia nervosa, a 30-year-old woman who reported feeling full and bloated after eating just several spoonfuls of cereal. She said that she liked the feeling of being empty and light when her stomach is empty. And this feeling fluctuated with several relapses and hospital readmissions, but never really completely resolved during her transition to recovery. So I want you to keep these cases in mind as we talk about interoception and mental health. As a physician scientist, my motivation and long-term goals kind of fall along these 3 areas, which you'll see highlighted throughout the talk. I'm aiming to discover modifiable neuroscience-based treatment targets that are linked to pathophysiological abnormalities in psychiatric disorders. Then, if we can identify those pathophysiological abnormalities, the attempt is to design tests to identify these treatment targets that are relevant for individual patients. And then finally, to develop neuroscience-based therapies that effectively modify these treatment targets and then effectively reduce symptom expression and other signs of illness. Now, my current focus is on interoception. Again, if you don't know anything about interoception, normally in a room I would take a poll of hands, but we don't have a polling system set up here. But maybe just reflect back on, at this point, how well you understand the concept of interoception. And we'll return to that later. So interoception can be defined by the process, as the process by which the nervous system senses, interprets, and integrates signals originating from within the body, providing a moment-by-moment mapping of the body's internal landscape across conscious and unconscious levels. Now, if you look at the literature, you will see papers that talk about interoceptive awareness, which can be defined as the conscious sensation, interpretation, and integration of information about the state of inner body systems. So these definitions were derived via a consensus process at the LIBR Interoception Summit meeting. And there's a special issue, and this was part of a white paper associated with that special issue that I would highly recommend checking out if you're interested. In terms of the history of interoception, modern English language references date back to Darwin's time, but the concept was present and considered even earlier. Charles Sherrington, of course, is credited correctly so with defining the term in 1906 to refer to receptors that are sensitive to internal body stimuli. Now, what you can see from this graph is that interest in interoception has fluctuated significantly during the previous century, but has undergone a bit of a renaissance during the current century. That's sort of evidenced by this part of the graph. Now, interoception is an incredibly interdisciplinary area of research, although most of the research in this area occurs within the fields of neuroscience, psychiatry, and psychology. And this is just a small sampling of 3 years worth of research, but I think it's pretty emblematic of what's going on right now. Now, interoception is critical for ensuring homeostasis. In other words, for maintaining a buffer against physiological threats to well-being. Some of those physiological threats I've listed on this slide. Now, the perceptual processing of interoceptive sensations is very tightly regulated. And in fact, most of the time, we're unaware of the physiological state of our bodies. But when sufficient physiological deviation occurs, our nervous system makes us acutely aware of such feelings, which should lead to corrective action to regulate and restore balance. So here's examples where maybe you might suddenly become aware of palpitations or dyspnea, lump in your throat, vasomotor flush. Some of these are symptoms of panic attacks. Others of these are clearly providing evidence of cardiac disorder, or at least of evidence that there's something happening within the cardiovascular system. Now, interoception is multidimensional, and there's many tasks that have been developed for studying its different features. This schematic here provides an illustration of several of the types of tasks that have been developed and studied over the past 50 to 60 years for studying cardiac sensation. And what we can do is for each of these tasks, we can divide them into different features, such as attention, where you would simply pay attention to your heartbeat sensation, versus tasks which measure the detection, the discrimination, the intensity, and the accuracy of that detection, as well as self-report using scales. So these tasks fall along a continuum. I tend to favor so-called heartbeat perturbation tasks because they tend to measure the most features, and particularly this intensity or magnitude estimation feature, which is kind of a measure similar to what you would get when you ask somebody to rate their pain level, right, from 0 to 10 or 1 to 10. Now, the situation is complicated because there's not just cardiac interoception. So unlike vision or hearing, which are canonical exteroceptive senses, the interoceptive system has a variety of different organ systems and physiological systems that are part of it. So genitourinary, gastrointestinal, respiratory, heartbeat, et cetera. And each of these could be studied and typically is studied in isolation. However, your nervous system and your brain are receiving these signals all the time simultaneously. And these signals have different characteristics. They vary in terms of the amplitude, and they also vary in terms of the frequency. And often they vary in terms of both of those processes simultaneously. So for example, your cardiac signal modulates quite rapidly relative to your respiratory system, relative to, say, urinary or even immune function. Okay? And so how the nervous system decodes these signals and how they're relevant for symptom processing and for mental health in particular is something of great interest to me. Now, with respect to psychiatric disorders, I would say that these represent one clinical area in which interoceptive dysfunction is commonly recognized. And let's not forget that it's symptoms that most often drive patients into the psychiatrist's office. Symptoms can be defined as the subjective sense that something is off, or that something in the interior or exterior milieu of the individual is perceived to be aberrant with respect to the usual state of affairs. Now, in this table, I've listed some disorders that show different combinations of interoceptive symptoms and signs that are drawn from Diagnostic and Statistical Manual 5 or DSM-5 criteria. Now, what I'd like to emphasize is that this description, which is consistent with current clinical practice, does not provide any information about the underlying mechanisms or the causes of these disorders. And I would argue that by linking brain and body, interoception may provide one component process for arriving at a better understanding of certain mechanisms and causes underlying disturbed mental health. Now, here's a figure from the review that Paul mentioned. So from the outset, what I would like to emphasize is that interoception is a neural process that traverses different levels. And the neural circuits of interoception really start with sensors, but they include pathways, networks, circuits, and finally this component of awareness, which is in and of itself related to perceptual processing. It's supported by neural circuits, which are again linked all the way back to these sensors in the body that are dedicated towards detecting the status of the internal body. They're different from circuits that are dedicated to detecting, let's say, other animals, other living beings, or non-living beings. The other thing that I would like to emphasize is that there are many non-conscious processes at play. So in other words, it's not just, interoception is not just about awareness of internal body states. There are a lot of non-conscious processes that have a fundamental role in ensuring interoceptive homeostasis. Now, this is some of the major brain regions that are involved in interoceptive processing. And I can tell you already that this perspective is incomplete and needs some updating, as you'll see later in the talk. I would say that the most commonly implicated cortical brain region in interoception is the insular cortex. But this map is intended to show you that there are a lot of subcortical as well as other cortical and brainstem regions that are involved in interoception as well, beyond the insular cortex. The other thing is that there are animal homologs of these regions, and there is a very rich amount of knowledge coming from interoception neuroscience focused on studying animals. The other thing that I would want to mention with this figure is that interoception forms the basis for regulation of internal body signals. So here, this arrow sort of symbolizes ascending or afferent information. But once that information is sensed, processed, and integrated, there are often descending regulatory, oftentimes motor or visceral motor commands. And this leads to this concept of a brain-body feedback loop. And so I want you to keep that in mind as we're going through this as well. Now, as I mentioned, the animal studies, there's a lot of progress happening in this area. I don't have time to summarize all of it. This is a slide that shows some discoveries over the last 7 or 8 years, but even this needs to be updated. So there are sensory neurons that detect stretch and nutrients in the digestive system that are part of the that are connected directly to the vagus nerve. There are differential expressions of mechanoreceptors called piezos that can be found in lungs, bladder, and skin that constitute a new class of interoceptive receptors. These play an important role in blood pressure sensing, in baroreceptors as well. And with respect to specific sensory systems like breathing, there have now been identified individual neurons that control different aspects of breathing, whether it's apnea pauses or shallow breathing. And finally, with respect to the gastrointestinal system, there's a whole bunch of discoveries related not only to the microbiome, but actually to neuroepithelial cells, which have these direct ability to sense what's happening in the stomach and other parts of the gut and transmit that information very rapidly to the brain in as little as 60 milliseconds. The only other thing I'll emphasize from these maps and these figures is that most of the animal neuroscience at this point stops at the level of the brainstem. You can see right here, usually at the nucleus of the solitary tract, whereas most human studies focus on cortical and subcortical networks above the brainstem. And so I would argue that connecting these streams of research would fill a vital gap. At this point, if we were all together in a room, I'd ask you to, by a show of hands, raise your hand if you can feel your heartbeat right now without taking your pulse. We're going to switch gears for a second to talk about the cardiac sensation. So most people can feel their heartbeat, but if you ask them when they feel it, it usually tends to be during a state of heightened arousal, like exercise, anxiety, stress, sexual activity, etc. Each of these experiences are notable because they signal a relevant change in your internal environment with either a positively or a negatively valenced connotation. But again, it's during that physiological perturbation that these interoceptive signals arise prominently in conscious perception. So if we took account of everyone who could feel their heartbeat, probably what would happen if we tested you all in the laboratory is we'd find about, on average, only 1/3 of you under resting conditions could accurately feel your heartbeat sensation. We did a study over 10 years ago, that show that even if you're a long-term meditator of two different traditions, Tibetan Buddhist or Kundalini, your detection rates are not that much higher. And in fact, and we replicated that last year using a perturbation method. And in fact, if you have somebody else's heart in your body, your detection rates are also not necessarily any better or worse. So this suggests that there's a fundamental floor effect in studies of cardiac interoception under resting conditions. What that allows me to do is to summarize that for the past 12 years, I've worked on establishing an experimental medicine paradigm that can objectively and safely measure interoceptive processing in humans in all subjects, not just a third, and that demonstrates feasibility for studying neural systems underlying interoception in psychiatric disorders. So it goes like this. We all know about the hypothalamic pituitary adrenal axis. Most people who study stress typically focus on cortisol because of its nuclear receptors and long-term implications in terms of genetic activation and translation and structure and function. I focus on studying the adrenergic side of the equation, and specifically what happens in the brain after adrenergic hormones like epinephrine are released. What happens in the brain in terms of representing that sensation? So this is the chemical structure of epinephrine or adrenaline. What we use is a closely associated compound called isoproterenol, which looks very similar, with the difference that it does not cross the blood-brain barrier, so it's a peripheral agonist, specifically of beta-adrenergic receptors, which are located most densely in the heart and the lungs. It stimulates beta-1 and beta-2s equivalently. And so what we've shown using a series of studies is that when you inject this intravenously, you can get a very nice dose-response curve in the physiological response. So this shows you a low dose of 0.5 versus a high dose of 2 micrograms that occurs within about 30 seconds of injection and comes back to baseline within several minutes. The normal heart rate ranges between 60 and 100 beats per minute, so you can see that we're able to exploit the full range of the normal physiology. We can then divide this into different phases, like a peak period, then a recovery to homeostasis period. And because we're interested in perceptual processing, we have people rotate a dial to indicate in real time the intensity or the magnitude of the cardiac and respiratory sensations they perceive. So that's this purple curve right here. And this is the associated rating. And what you can see is that for a 2 microgram dose on average, we get very nice concordance between the sensation and the physiological response, albeit with a bit of a delay. In healthy subjects, we have done careful sort of visceral psychophysics dose-response curves using very small as well as very high doses. And these represent the average dial time courses of perceptual awareness. So you can see at the high doses, pretty much everyone feels it with a nice curve that matches the heart rate. Whereas at that sort of lower 0.5 microgram dose, there's some response, but it's not a super large one. And what you can do is look at the detection rates and see that, that the 0.5 microgram is sort of in between the placebo response rate of about 30% and the maximum response rate where we get 100% of people able to feel a 2 microgram dose. We've done some work to look at the localization of the heartbeat sensation using these body maps where people trace where on the body they felt their heartbeat during either the placebo or different ISO infusions. I should mention that these infusions are given in a randomized double-blinded fashion, so there's the placebo control. And what this shows is that the highest doses, people tend to most prominently feel their heartbeat in the anterior chest wall, which corresponds to the mid-systole when the heart actually twists forward and kicks against the inside of the chest wall. This is kind of similar to an area known as the PMI, or point of maximum impulse. So we've done some functional neuroimaging studies. I'm going to summarize these here. What this showed is that during the peak period of responsiveness to a 2 microgram dose, we see a focal insular activation in the mid-insula on the right. This region is unique as it's the first subregion of the insula to receive sensory input from the ventromedial posterior nucleus of the thalamus. What was interesting in this study is that when we looked in that recovery back to homeostasis phase, we found an expansion to activation across other sectors of the insula. suggesting the occurrence potentially of crosstalk among these insular subregions during homeostatic recovery. Now this was a very nice focal targeting, but it made us wonder whether this region was dysfunctional in psychiatric disorders. By the way, this also actually represents our second study. This was a previous study where we replicated the activity, the focal targeting of the right mid-insula. So this is some unpublished work that I'm pleased to share with you that's led by a talented postdoc. So this focuses on cardiovascular hypersensitivity in generalized anxiety disorder. So GAD is the most common anxiety disorder in the US with functional impairments comparable to that of depression. It's replete with somatic symptoms like muscle tension, restlessness, fatigue, and headaches, in addition to excessive worry. But the conventional clinical nomenclature-based accounts emphasize it as the least likely of all anxiety disorders to exhibit symptoms of autonomic hyperarousal. This may be, in fact, due to a historical wrinkle. So in the 1960s, Don Klein showed that imipramine, a TCA, could block peripherally triggered symptoms of panic attacks, and in other studies, lower heart rate, whereas centrally acting benzodiazepines were more effective for generalized anxiety. So this, over time, helped to codify clinical stereotypes of anxious arousal for panic and excessive worry for GAD in the DSM. However, GAD patients actually report seeking evaluation for cardiological symptoms at the same rate as those with panic disorder. So in the current study, we decided to take a closer look at cardiovascular sensitivity in GAD with isoproterenol. So what happened was we studied a group of females with GAD and in a randomized double-blinded approach, gave them sort of 0.5 and 2 micrograms in saline of isoproterenol. What we found is that there was a selective difference in the group response at this sort of sub-threshold dose where the GAD patients had heightened heart rate responses. Here you can clearly see that both groups had very large responses at the maximum, but they didn't differ during the saline. When we looked at their perceptual ratings, we found that GAD subjects also showed heightened perceptual responses relative to healthy subjects, again, only at the 0.5 microgram dose. So you can see here the average peaking at an intensity of about a 1 versus an intensity rating of about a 3. When we looked at an indirect measure of peripheral beta-adrenergic receptor density, something called the CD25, we found evidence for hypersensitivity such that the GAD subjects had lower CD25 levels. And importantly, this adrenergic receptor finding seemed to be specific to the cardiovascular system and not the respiratory system. So this is a depiction of respiratory response variability showing that for both the doses, both groups actually do show changes in their respiratory pattern, but there aren't any group differences. So these results suggest that cardiovascular abnormalities of the peripheral nervous system may be associated with the anxious pathophysiology of GAD. Now, keep in mind that isoproterenol doesn't cross the blood-brain barrier, so these estimates are focused in the periphery. The other point is that keep in mind that the nervous system includes the central nervous system and the peripheral nervous system, the peripheral including the autonomic and the somatic nervous system. So again, this is an argument for a role of the peripheral nervous system in the pathophysiology of GAD. Of course, we're very interested in the central nervous system as well. So during this paradigm, we collected functional brain imaging measures. And our hypothesis was that the GAD group would actually show heightened and abnormal insular responses relative to healthy comparisons. This it actually was not the case, even though we found evidence across both groups of dose-specific increases in mid-insula, kind of more on the ventral side. We did not see any evidence of group differences in the response. Instead, when we looked across the whole brain in other regions, we found a selective hypoactivation of the ventromedial prefrontal cortex during the peak period and the early recovery period. Again, only at the 0.5 microgram dose. So both groups showed hypoactivations with higher doses, but this group difference was present only at the 0.5 dose. Now, That was an epoch-based analysis, which was a bit constrained by our a priori hypotheses. What we wanted to do next was to look at a more data-driven approach. So this shows an example of the time course of activity for the cluster and the VMPFC. What we did separately, because we can't really do an epoch-based analysis on this results because this is defined based on the group difference. We took regions of interest from meta-analyses focused on self-processing, autonomic processing, and valence processing, and using a tool called multivariate functional principal components analysis, which is kind of a principal components analysis that allows you to look at functional scores or components across a longitudinal time series in a data-driven way. When we extracted signal from the different ROIs, we found evidence for differences in component scores only, again, at the 0.5 microgram dose between groups. In this case, this is from a self-processing ROI. We did see some differences related to the autonomic processing ROI as well. So this study suggests that autonomic hypersensitivity and blunted VMPFC activity during peripheral beta adrenergic challenge is relevant for GAD. And this could help serve as a treatment target to help anxious patients more appropriately appraise and potentially regulate sympathetic arousal signals emanating from the autonomic nervous system. The basic finding, again, in the brain is this notion that there's a failure of the VMPFC to constrain moderate levels of centrally originating sympathetic arousal, or colloquially, kind of when the adrenaline spikes, your brain shuts down, or when the adrenaline spikes, your VMPFC shuts down more if you're a GAD subject. Now, why is the relevance of autonomic hypersensitivity in generalized anxiety important? Well, it turns out that disrupting descending CNS arousal is also a key target in the treatment of refractory cardiac ventricular arrhythmias. So this is a figure from a paper from a cardiac electrophysiology colleague of mine at UCLA, showing that for the strategies for modulating ventricular tachyarrhythmias fall in two camps. You either decrease sympathetic activation or you increase parasympathetic drive. And in particular, one thing that they've been studying at UCLA is interruption of sympathetic efferent fibers to the heart using something called cardiac sympathetic denervation, where you literally snip T1 through T4 and a portion of the stellate ganglion, which provides excitatory adrenergic input onto the heart. The way that the cardiologists have described this to me is that it's literally an effort to reduce the supratentorial, or essentially the brain influences on the heart. And it turns out it works. It actually seems to improve mortality rates by as much as 50%. Now, we looked at the association recently between this procedure and mental health. In a small group of 10 patients, we found that cardiac sympathetic denervation was actually associated with reduced anxiety symptoms after treatment for these refractory arrhythmias. Again, not responsive to any other drugs. However, depression and PTSD symptoms were elevated and unchanged. And so this has led us to suggest that screening and longitudinal surveillance of ICD patients is warranted to monitor the impact of this procedure on mental health. If you're interested in some more reading, we actually previously implemented a care model for these patients a number of years ago. I'm going to switch gears now and turn to some other relevant psychiatric disorders. In order to do so, I need to introduce you to the Tulsa 1000 study, which is the brainchild of Martin Paulus, LIBR's scientific director. This is a naturalistic longitudinal study of 1,000 individuals with mood, anxiety, substance use, and eating disorders. You can think of it as a deep phenotyping study where we collect a lot of behavioral, biomarker, genetic, microbiome, inflammatory markers, imaging measures of these individuals, follow them quarterly for a year, and now we are in up to our 5-year follow-up time point. We're currently in the process of analyzing the first 500 sample, which is considered a training sample, and then the next 500 we'll be looking at to see whether the findings in the first 500 can replicate. So in the first study I'm going to show you, we decided to look at the relevance to suicide, basically the relevance between interoception and suicide. So Tom Joyner, who's one of the leading figures in suicidology, has suggested, based on his decades of research, that acute states of sympathetic overarousal are commonly observed prior to near-lethal or lethal suicidal behavior. So he's written about this. He has collected YouTube videos of people who posted videos of themselves just prior to ending their own lives. In those cases, he's interpreted evidence of autonomic hyperarousal, including pupillary dilation, hurried breathing. What we thought, based on these sort of concepts, was could we see evidence of abnormal interoception in people who had attempted suicide in the T500. So what we did is we extracted out suicide attempters, defined as those reporting a serious attempt within the past 5 years. And what we did is we looked at their performance on an interoception battery that was included in this study. So the first was a breath hold task. We found that suicide attempters were able to hold their breath longer, 12 seconds on average, than psychiatrically matched non-attempters. These are people who had the same levels of anxiety and depression symptoms. Now, both groups felt pain at the same degree, but once they reached their maximum pain levels, or their pain tolerance in the suicide attempters was actually higher. They kept their hands in the ice water for 20 minutes on average, 20 seconds longer on average. The suicide attempter group also had lower heartbeat perception accuracy, and in an interceptive attention task had lower right insular cortex activity when specifically attending to heartbeat sensations. We've done a follow-up study where we looked at remote suicide attempters, so people who attempted suicide more than 5 years ago, and we found that those individuals also had greater pain tolerance during a cold pressor challenge and lower suffocation feelings, but we didn't see the same cardiac interoception findings. So we interpret these findings as suggesting that suicide attempters exhibit an interoceptive numbing characterized by increased tolerance for aversive sensations and a decreased awareness of non-aversive sensations. Of course, these are attempters and these are the people who survived, so we really can't say anything about suicide completers. Moving to other disorders, this was a study led by a grad student in the lab looking at respiratory responses and pain responses, and finding that individuals with mood and anxiety disorders, as well as eating disorders, both reported heightened feelings of suffocation and suffocation fear than demographically matched healthy comparisons. What was interesting to us is that it was the eating disorder group that actually had significantly higher feelings of suffocation even than the mood anxiety group. This finding or general pattern held true when we looked at subgroup analyses focused on anorexia nervosa. And importantly, both the patient groups didn't show differences on a cold pressor task or any differences in their physiological response. So this was kind of interesting, and this is a line of research that we're going to be following up on because it suggests that abnormal respiratory interoception may be a common but potentially overlooked clinical feature of eating disorders. Walt Kay's group at UC San Diego has done some great neuroimaging work in these patients looking at inspiratory breathing loads, but we think that this could be something that has some clinical traction as well. All right, so I'm going to switch gears again to talk a little bit about computational models of interoception. So what I want to say is that sensation and regulation form complementary aspects of the brain-body feedback loop. An organism translates incoming information about an internal state, this red arrow here, from its sensors into appropriately adjusted actions that are executed by its effectors, this blue arrow. These actions in turn alter the internal state here in gray, and therefore the future sensory inputs, resulting in a circular relationship between states, sensations, and actions. Now, importantly, internal states can be informed by both interoceptive and exteroceptive sensors. Now, computational models of interoception are inverse models, and that's sort of depicted with this dashed arrow, dashed black arrow, in which new incoming sensory information, which depends on the current internal state here, is combined with a priori expectations about the internal states or priors to form this notion of a percept, or posterior, okay? So basically what you feel is the combination of what is being relayed to your nervous system in real time, as well as kind of what you expect to happen. This is an example of, this sort of example can be applied to phenomenon as basic as a baroreflex response. But this notion of these reflexes can be applied to the hierarchical organization of the nervous system. There are a variety of different computational models that can do this. What we're showing here is one example of predictive coding that kind of illustrates this same sort of reciprocal reflex. But the notion is that as you go from primary to secondary and higher order polymodal association areas, that the information that's being parsed and fed back, expected, interpreted, and sensed gets digested in different ways at different levels, okay? There are a number of advances in the computational modeling of interoception that are happening. If you read this paper, you'll get a nice overview of them. One reason we put the mouse here is that we would argue that these kinds of models could be applied to animal studies as well. Now, if you look at the literature, you will see a lot of discussion of computational models of interoception. This is a small sampling of the different studies that are out there. Again, these are all theoretical, and they're kind of complicated. I don't have time to go through all of them, but suffice to say that these notions of predictions and prediction errors, mismatches, priors, expectancies, forecasts, these all play out not only with interoceptive predictions, but also with exteroception and proprioception. Through modeling, they can be evaluated within the context of different brain regions. Okay, most of these are theoretical. I like this one in particular from Klaas-Stefan because of the following. It illustrates this notion of allostatic control or predictive control. So here's an example of a hypothetical organism who's at a physiological state X. At this level, a perturbation happens which shifts the organism out of its homeostatic state. It perturbs it. Now, over time, with repeated perturbations, which could potentially threaten well-being and homeostasis, the organism learns to deploy allostatic control and thereby shift its state in anticipation of the perturbation, such that the next time the perturbation occurs, you can see that the deviation is no longer as far down here, and the organism remains closer to this homeostatic set point. Now, these shifts and the anticipation of the shifts can be modeled. This is something that's a parameter called prediction-weighted precision error. These models are incredibly powerful for seeing these anticipatory and sort of seeing some of these hidden state changes. But again, most of them are theoretical. We recently reported the results of a computational modeling approach to interoception, specifically cardiac interoception in the T500. This is work led by Ryan Smith. I don't have time to go into the details if you want to read the paper. Basically, we used a heartbeat tapping task. So they tapped a button every time they felt their heartbeat. We included a few different instruction conditions, and importantly, this breath hold that was intended to increase the afferent strength of the heartbeat signal, make it easier to feel the heartbeat. And what we found is that using a computational model, a parameter called interoceptive precision, when the afferent signal got stronger, only the healthy subjects were able to update their precision estimates and give higher weight to the afferent signal. None of the anxiety, depression, eating disorders, or substance use groups showed this shift. And the inference here is that maybe in certain psychiatric disorders, the brain may treat afferent body signals as though they're not reliable indicators of bodily states. And this could lead to perception being insufficiently constrained by true visceral states. If that happens, then perception should be primarily determined by, in many cases, your prior expectations, which are hypothesized to be inaccurate or maladaptive in these disorders. Now, we recently replicated this finding of increased precision in a group of healthy individuals, a separate sample, And we're looking forward to replicating this in the second T500 data set of patients. I want to illustrate very quickly this notion of expectancies. So, and there's a long history of this. If you look at this, you probably see a bowl of fruits and vegetables. But if you change the orientation, this is a painting from the 1500s. You probably see the vegetable gardener now. You see his nose and his mouth and his eyes. And now that you've seen it, you can't really unsee it, right? You have an expectation, and you can, even though the orientation is the same as it was before, your brain can kind of bind those features together. So there are a variety of exteroceptive illusion examples. This is one example in the auditory perspective. Laurel or Yanni that was reported on a couple of years ago in the New York Times. But the bottom line is that your nervous system can be confused by ambiguous sensory data. And you can interpret the same signal, the same auditory wave, as a laurel or a Yanni, a green needle or a brainstorm. I don't have time to show you the illusion. The same thing applies, we think, to psychiatric disorders. And we showed in a previous study in anorexia nervosa that when patients were anticipating meals, even though they could discriminate the isoproterenol related signal, they had higher detection curves with higher doses. When they were anticipating an anxiety-provoking meal, it was during saline infusions that they misperceived selectively the cardiac sensation. We developed a statistical methodology for actually analyzing the localization body maps. And this is the body map that showed that the AN patients were statistically localizing a false sensation to their body during the saline period, but again, only during the pre-meal period. So this suggests that individuals with AN may exhibit a heightened vulnerability for experiencing visceral illusions. I've shown you sort of a couple studies now that relate to cardiac and respiratory, and you're probably scratching your head saying, well, that's fine and good, Dr. Khalsa, but these are eating disorders. These patients don't eat, right? So what about the gastrointestinal system? So we have begun studying that. The challenge is that studying GI perception is difficult without resorting to invasive means, such as swallowing inflatable balloons or placing them anorectally. But what I'm pleased to report is that we've developed a minimally invasive approach to studying gastric interoception, which I'll outline here. So this is our vibrating capsule study. There's a company that has developed a non-pharmacologic approach to treating constipation. The idea is that the vibration of the capsule in the colon will stimulate the colon to contract and release stool. In this case, we've reprogrammed it to go off in the stomach. I won't bore you with the details, but basically using a signal detection paradigm, patients, healthy individuals can feel it. And when we increase the strength of the signal, they feel it more with reduced response latencies. We've done evoked potential recordings, and we see a very nice evoked response potential, but surprisingly in posterior midline regions with a strengthening of that signal in the enhanced condition. So when I said previously that the map of neural circuits of interoception needs to be revised, we probably need to add some of these posterior midline brain regions. And there's some imaging evidence from Catherine Talon Baudry's lab that supports this. So this approach basically shows that I think there's an opportunity to understand the role of gut-related symptoms, not just in eating disorders, but even physical disorders, such as functional neurological disorders, functional bowel disorders, where there's a lot of bloating and cramping that are also symptomatic. And we're currently studying this right now in individuals with anorexia nervosa. Okay, I want to be mindful of the time. This is a talk that also includes an integrative medicine component. So I'm just very briefly going to highlight the last part and then I'll finish up. And that is talking about flotation rest. So something called reduced environmental stimulation therapy. This is a non-pharmacological form of perturbation. It was initially developed during the space race of the 1950s to test astronauts' abilities to tolerate the anti-gravity environment of outer space. Here's an example of the first sort of chamber. People were floating underwater with a helmet on. However, there were some salubrious effects that people reported: feeling calm, feeling energized, sleeping better, more creativity. As a result, a commercial float tank was developed. And you may have heard of float centers that have popped up across the country in the past decade. This is an example of a commercial float tank. People are paying to float, most often 60 minutes or 90 minutes, kind of similar to what would happen with a massage. We became interested in understanding whether this might be useful as a potential anxiolytic tool and for studying interoception. My colleague Justin Feinstein at LIBR actually built an open float pool based on his interest in studying the effects in individuals with anxiety disorders. So this is the open float pool at LIBR. It's an 8-foot diameter circle, 11 inches of water, 2,000 pounds of Epsom salts. The water is heated to the surface of the body, and so is the air. You can stand in the water, but when you lie down, your body surface area increases and you bob on the surface. You float without even holding your breath or treading water. The room itself is noise-proof and light-proof, so you can open your eyes when it's dark and not even a photon of light hits the retina. So it's a very highly engineered environment. That much is true. The way we think about it with the nervous system is that if this is your brain, these are all the systems that are receiving reduced input, right? There's no sound, there's no visual input, you're not talking to anyone, you're not moving. And what this leaves room for, of course, is for interoceptive input to be relatively heightened. When we've studied this in anxious individuals, we found that intensity ratings of breathing and heartbeat sensations were increased relative to watching a film. This was a randomized, this was a within subject crossover design when people were watching a documentary film in another condition. We found that heartbeat localization was increased during the float. And importantly, we found ratings of heightened relaxation and reductions in muscle tension and state anxiety, as well as diastolic blood pressure changes. So we're finding actually that this has a potent, at least short-term anxiolytic effect. And we're interested in seeing whether this compares to the effects that you might get, for example, with a benzodiazepine. In a separate set of studies, we're doing clinical trials with eating disorder patients. This is our safety study. I won't go into it, but we found that floating was safe. We've actually just completed a efficacy style study of 66 patients randomized to either floating or usual care for anorexia nervosa in patients. We've had good follow-up rates and our endpoint analysis is ongoing. So with this, I'd maybe reflect back on how much you understand interoception. If you still want to learn more and read more, there's a special issue on interoception published in Trends in Neurosciences in January. There's also a notice of special interest focused on interoception that's around for the next 3 years. So NIH, particularly the Neuroscience Blueprint Institutes, are interested in this. That effort's led by NCCIH, I might add. If you want to read some books about interoception, here's a dozen books. If you didn't get them, email me and I'll send them to you. But to summarize, I would say that interoception represents a component process for arriving at a better understanding of certain mechanisms and causes underlying disturbed mental health. I've shown you increasing evidence of interoceptive dysfunction in certain psychiatric disorders. Hopefully, I've illustrated a conceptual framework for probing interoception in mental health that may ultimately suggest internal sensations as potential therapeutic symptom targets. And I've highlighted some novel approaches for clinically modulating interoception and conscious experiences of internal sensations. But really, there's some rigorous clinical trial work that still needs to be done. I'd like to thank everyone in my lab and my coordinators, and I'll take your questions.
All right, thank you, Dr. Khalsa. That was quite impressive, the amount of data and impressive results and research that you're doing in the area of interoception, and to get through in that time frame, congratulations, really nice talk. I hope we have time for a few questions from some of the participants.
Go ahead and unmute yourself if you have a question.
Okay, I'm Mohammed Kubaisi from the Department of Neurology. I'm interested in your opinion in Damasio's views that the internal unconscious computations, which determine most of cognition, and also art production for that matter, occur via affect encoded internal sensations, which are processed by the insula and likely other structures.
Yeah. Well, sure. I'm happy to talk about it. I trained at Iowa in Damasio's group. I'm familiar with his work and his perspective. So from the outset, he's always defined the difference between emotion and feeling, right? As emotion being sort of the physiological parameters that are associated with the subjective experience called feeling, right? Feeling is sort of essentially your interpretation of those signals. So I think that's very much compatible with interoception. He has always written about interoception. In fact, he was one of my inspirations for studying this area. It was clear that there was such a gap in our knowledge. There have been a lot of studies in the Czech Republic, for example, and in Russia, non-English language studies in the 50s and 60s, but there's a real gap there. The thing is that when Damasio has talked about emotion and consciousness, he talks about, for example, the inaugural moment, this sort of moment when consciousness first happens for the organism, and he sort of in the feeling of what happens, he sort of likened it to the actor stepping onto stage, right? And so that's a very powerful metaphor. Of course, that only begins the process, right? Everything is in life is from what happens for the rest of the play, right? And the thing is that to continue to use the metaphor, the response of the audience and the performance itself varies based on the day, the season, who's in the audience, the state of the individual. And so I think that what is important about computational models is that they actually are able to account for that history and yield discrete parameters. For example, precision parameters, prior expectation parameters, learning rates in response to changes in input over time. And so I think that framework is going to be incredibly useful for getting a more inside view, looking at these hidden states, looking at how the brain is really inferring the meaning of the world inside the body and the world outside the body based on its available signals. So how that relates to art production, I mean, I think this framework could be applied to art experience just the same way you can apply it to neurological or psychiatric patients. I think for society's direct benefit, the proximal application really should be, physical and mental health disorders. So thank you for that question.
Thank you.
Thanks so much for that talk. I found that really fascinating. I am curious if you could talk more about the role of the autonomic nervous system in the process of interoception. So I'm thinking specifically about people who have dysautonomias or autonomic dysfunctions and how interoception might be altered in those cases.
So are you a neurologist?
I'm not. I just have a particular interest in dysautonomias.
So ask any neurologist about their Parkinson's patients, right? And a neurologist worth their salt will tell you when that one of the early manifestations, not of every Parkinson's patient, is dysautonomia and constipation, right? And cardiovascular problems. In some cases, arrhythmias, right? That sort of tangled webbing that is the autonomic nervous system that basically automatically maintains homeostatic well-being of these various organ systems, for some reason goes awry in Parkinson's. And understanding the basis of that, right? Understanding whether that might even be an earlier indicator than, say, tremor, right? Maybe there might be individual differences in people who are at risk for Parkinson's, who have subclinical constipation or subclinical cardiovascular issues that then play out at the level of the function. It's not necessarily that you need to have a study of how well they perceive their gut or their heartbeat, but it's sort of this interplay between the functional output, right, the regulatory output, meaning how well the heart actually beats, how well bowel functioning works. So I think that's kind of one example. And the cardiac arrhythmia example is another one. I mean, these arrhythmia patients have really heightened interoceptive experiences. I've treated patients who had very heightened salt sensitivity, for example, and they felt like even the slightest amount of salt, or atrial fibrillation patients who the slightest amount of alcohol they felt could trigger their arrhythmia, right? In some cases it was true, and in some cases it wasn't. And so the challenge there is, how do you define the role of the autonomic nervous system, but then also separate it from the symptom reporting, which sometimes relates to the autonomic process, but sometimes has more to do with the central process.
So I'm sort of curious because I'm thinking about, I guess, in a situation where you have a autonomic dysfunction taking place, you know, you're thinking about and aware of, in some cases, these processes you're normally not aware of.
Yeah.
And how, I don't know, I'm curious about this idea of how your expectations potentially are molded by the fact that you know you have this condition maybe, and how that might, I don't know, interact with the fact that you're also already having heightened interoception because of the situation.
So Richard Brown writes beautifully about functional neurological disorder, which which I didn't talk about, but it's a disorder where patients will have report an abnormal sensory or motor phenomenon. In some cases, they will have an abnormal movement that is not explained by a traditional neurological exam or neuroimaging. There's no discrete lesion that makes anatomical sense. Another version of this has classically fallen within psychiatric disorders. It used to be called conversion disorder. Psychogenic non-epileptic seizures is another sort of condition that falls within it. And he writes about this concept of a symptom scaffold. And you know, again, the symptom being the thing that the patient reports as being wrong, the thing that they feel is wrong. It may be a direct one-to-one translation of a physiologically observable abnormality, but it may also not be, and it may be influenced by a layered process, things like a family history of trauma, low education, a recent sort of traumatic experience that is different from a childhood trauma, or maybe a superimposition. But even beyond that, sort of this notion of how an individual goes about making meaning out of the signals that are available to them. So in the example that I gave in the beginning of the ICD patient who had one shock, right? The ICD shock is a abnormal, it's a sensation that those patients have never experienced before in their life when they first get their shock, right? It's physiologically implausible. And it can fundamentally reorient how they interpret, how they focus on the body, how willing they are to take action or to be inactive in relation to their prior life. And so I do think that computational models can help unpack that process. But I do think there's also studies that need to be designed from a perspective of looking at those dimensional layers in greater detail. Is that helpful?
Yeah, thanks. I don't know that there's really an answer yet. I just think it's a really fascinating intersection of those two things. So thanks for talking about it with me.
Yeah, I don't think there's an answer. It's really, I mean, really what we're trying to delineate here is how we can study it and how we can help patients and help, honestly, other healthcare providers realize that that some of these symptoms are coming from a place within the nervous system. You know, it's not just sort of within their head. I mean, yes, it's within their head, but it's within their nervous system. And the challenge and the goal is to delineate where in the nervous system it is and what the abnormality is so that that can be targeted in a therapeutic context.
Right. It's awesome. Thanks so much.
Does anyone else have any questions for Dr. Khalsa? I would like to get one in, Sahib, if you don't mind. Are you okay with time?
Yeah.
Okay. And I just want to make a comment too, for those interested in any aspect of interoception research that you learned about today, in terms of funding, the NCCIH at the NIH has put out an RFA that I'll actually just put in the chat box right now if you want to have a look at that as well. So Sahib, but sort of big picture question that I wanted to pose to you with regards to interoception and its applications in treatment of physical and mental health, or prevention of treatment of physical mental health disorders. How do you perceive, or at least fit in, aspects of developmental disorders and this area of, sensory processing disorders in younger children? And obviously this has important applications, but it's almost my impression that they're almost as if they're two different fields.
Yeah.
And I'm just wondering whether, the fact that these surges in autism diagnoses, and they have sensory processing disorder clinics for children and identifying these things early on, I'm wondering if this is an important component that, or at least a something that we'll be having to deal with later on as these individuals as adults, and whether or not, this patients that you see, were they diagnosed with a SPD as a child, or so how do you, how is this field, how does this field view that?
Great question. So I would say at this point, even calling it a field is an achievement, because it's a small area of science that is growing, but I think over time, hopefully, there will be a field of interoceptive neuroscience, just like there's cognitive and affective neuroscience. The notion of skin sensitivity and hypersensitivity in autism, and this notion of sensory processing disorder, strikes directly at the heart of a debate about what interoception is and isn't. Is the skin a sensory organ focused on the outside of the body, or focused both on the outside and the inside of the body, right? I think the current consensus seems to be that it does both, and that interoceptive signals that arise from within the body, like vasomotor flushing, et cetera, can still be interoceptive, even if they're being perceived using receptors that are kind of primarily oriented towards external environments. There really isn't enough literature to look at the abnormalities of interoceptive processing in psychiatric patients to then look back and say, oh, this can be explained by an autism or sensory motor or sensory processing diagnosis. Most of the studies actually exclude for autism. And so I think that there's a viable area of research that can advance that can be made just focusing on autism. But those two connections haven't been made directly. I will say that I didn't talk about a study that was done in the 70s. It was in Science, where these were animal researchers looking at rat pups, and they were looking at conditioned learning. And what they found is that rat pups that were less than 10 days old showed a preferential sensitivity to conditioned learning when the signal, in this case a shock, was delivered to the peritoneum of the animal, but not when it was a sound or a smell. When the rat pups were 10 days old or more, so they had undergone some developmental transition, they were now more sensitive to conditioned learning using the auditory stimulus shock. And it was a shock to the skin versus a shock to the peritoneum versus a predator odor. And I can send you that. So the idea is that maybe there are these sort of developmental windows that have key relevance for interoception. Potty training is another one. I think there's a sort of a need to understand both of these processes, but there really isn't anything linking them at this point.
Okay, thank you. Does anyone else have any more questions for Dr. Khalsa? Okay, well, thank you again, Sahib. This has been really wonderful. I appreciate you taking the extra time for the questions, and I'll be in touch as I have some questions with the Isoproterenol studies and
Sure.
And the ICD ongoing ICD studies. So thanks for an update on that work, and it was really great. So. And I want to thank Jeanette too, as a co-host from the Integrative Medicine Department, for helping advertise and put this together. Jeanette, I'll be maybe seeing you next week as we plan for next year's symposium. So take care, everyone, and it was really great. Thanks for attending.
Thanks for having me.
All right, take care.